Okay, so we are ready to go for the next part of this morning. So we've looked at case study design, and we've said that case study design is something that is often used. You'll see it in health policy and systems research. But when you see it, I want you to always be critically aware, because a lot of people will mix up exactly what is meant by a case study. So very often we think that a case study is because we're doing it in two states. No, it is. The case study is always the phenomena of interest. And as we said, it can be more specific and it can be less specific, okay? So now we wanted to move to, it's not really a study design, but I think it's very important to talk about evaluation in health policy and systems research, because a lot of research that we're doing in health policy and systems research, even though it might not be explicitly referring to evaluation, somehow we are evaluating some aspect of the system. So in all four of our cases, in fact, there is some intervention or some systems issue at heart. Whether it's integration of a new health workforce cadre, whether it's a PPM, whether it's trauma care. And remind me of the last topic, which I've forgotten, digital literacy. So all of those are things that are being tried out in the health system. And even though in the studies that you might be doing, you might not be conducting an evaluation, you are still indirectly kind of researching why things might not be working the way they should be working. So there is a normative evaluative component to your work, right? Okay. Okay, so we're going to go over why evaluate. What's the purpose of evaluation? I'm going to suggest that context matters in health systems evaluations, just like it does for case studies. And we're going to discuss what makes an intervention complex. And then I'm going to give you a small example from some work that I did in South Africa some years ago, back in 2014-15, to show you an example of why it was difficult to evaluate what seemed like a simple intervention. So why evaluate? So generally, health systems research, global health in general, global health and development, is trying to change or improve certain outcomes for individuals, that might have a condition, for communities, for health systems. And those changes or improvements are delivered through routine services, through programs, through projects or research interventions. And we want to know, because we're putting a lot of money into these places, we want to use our resources in an impactful way. Are these programs or interventions reaching their goal? How do we actually know that this program is working or not? Is it effective? Can we improve it? Can we refine it so that it works better to achieve its goal? Can we scale it up? Seems to be working in one state of India. Can we spread it across the country? So what is it we need to know about that program and how it works to be able to scale it up? Among many different programs or approaches, what do we prioritize? So this is part of the rationale for evaluation. Now, what's the difference between evaluation and research? So in academic research, which many of you are involved in, that is primarily focused on testing hypotheses. And you have an idea about why public-private partnerships aren't working as they should, or you have an idea about why it's difficult to take up the digital literacy program. And you're testing it. You're testing it in some ways because you're exploring the reasons why this isn't happening, given certain contextual constraints or conditions that might explain why the program isn't being taken up as it is. Whereas in evaluation, your key objective is not just to document, right? Or to describe or to explain. It is actually to improve something, improve the practice. So this is a quote from a famous evaluation expert. Research seeks to prove, evaluation seeks to improve. Research is often conducted in a controlled environment or using control groups, as certainly positivist research is, and it's unrealistic in real world settings. Unlike pure research models, program evaluation actually incorporates the differences in values and perspectives from the start. So most research that's conducted on health and health outcomes tends to try to control for confounders. And I'm arguing that health policy and systems research is often somehow, even though we don't explicitly call it evaluation research, but it is actually incorporating consideration of those contextual factors from the beginning. And you may be addressing questions other than direct attribution. We're often trying to produce results for different stakeholders. What drives evaluation? So evaluations drive, and they involve value judgments. So is a program or project effective? What do we need to know to make the program better? Is it worth the resources spent? So this value judgment relates to the word normative or evaluative. That's why we say normative or evaluative, right? Because we're assuming under an ideal case scenario that this program or this intervention should deliver what we expect it to deliver. Evaluation is also systematic, so we're using research to carefully collect information about a program or aspects of the program in order to make decisions about it. And it's iterative. You never stop doing evaluation. So ideally, we have what we would call, the term is often called a learning health system. So in a very good health system that works to improve itself, it is incorporating information about how to improve or change a program on an ongoing basis, because we acknowledge that no program or intervention, no matter how promising it was in the beginning, is going to be perfectly implemented or achieve its goals in a uniform way. So where does the impetus, the stronger impetus, come from to evaluating global health and development? So this is just a quote from the Lancet 2010. It's an article which was talking about the need for better evaluation in global health and development. Evaluation must become a top priority. Currently, it's only an afterthought. A massive scale-up in global health investments during the past decade has not been matched by equal commitment to evaluation. So remember, this is the time period where mid-2000, 2005 through 2010, health system strengthening was on the agenda, the realization that delivery of interventions like antiretroviral scale-up or TB diagnostics we were investing a lot of money in these large-scale programs, especially in the global south and especially in the poorest countries in the world. But we weren't really spending a lot of time evaluating whether we were getting the best outcomes for our investments. So this complacency is damaging the entire global health movement. Without proper monitoring or accountability, countries, donors, taxpayers have no idea about whether their investments are really working. A lack of knowledge about whether aid works undermines everyone's confidence in global health initiatives and threatens the great progress made so far. So this is just to remind you of the scale of money, external donor funding, during the period 1990 and 2019, the massive changes in the funding architecture, especially across the poorest countries, regions of the world, Southern Africa and so. So clearly with the scale up of the funding and the appearance of major funding initiatives like the Global Fund, there was more of a drive to improve our evaluation methods. So this is another paper that came out recently. This is 2018. And this is about moving towards quality, improving the quality of health systems in the context now. Before it was more about Millennium Development Goals, then it changed to Sustainable Development Goals. And this was a very influential paper because it was basically arguing that although health outcomes have improved in LMIC, a new reality is at hand. Changing health needs, growing public expectations, and ambitious new health goals are raising the bar for health systems to produce better health outcomes and greater social value. We propose that health systems be judged on their impacts, including better health and equitable distribution, on the confidence of people in their health system, and on their economic benefit, and processes of care, consisting of competent care and positive user experience. So this is a little bit of a shift, right? Because the earlier drive to evaluate health systems was an economic one, versus this one is more about the quality and the fact that the systems should be responsive to the needs, should be meeting needs and expectations of people. So the move towards high quality, people-centered health systems is a different driver to evaluation in the late kind of post-2019. So drivers include that the effectiveness of many health interventions in low and middle income countries has not been adequately demonstrated. Interventions that seem to be effective in rich countries may not be effective in poor countries, with the differing social, economic, cultural, and infrastructural factors. Overseas development assistance is always subject to evaluation, and we've seen that now with the Trump government coming in, who decided to cut all US funding, which has had a severe impact on so many programs around the world. But basically, his argument is coming from that standpoint of that if we don't have enough evidence of what is working where, we better put everything on hold. Okay. Agencies have increased funding for evaluations and implemented new evaluation policies, and it's become a field of science in and of itself. So you may have heard of implementation science, but there is a whole field of academic discipline now called evaluation science as well. So the other driver is scaling up of intervention. So many health interventions are implemented at a small scale, and they're limited to specific areas. They're not sustainable. And we want to understand, how do you deliver a proven health intervention to an underserved community? How do you actually go about scaling it up, given that sometimes sustainable infrastructural requirements or financing requirements are not in place? So why would you introduce a new initiative if you can't guarantee that you're going to be able to sustain it over a period of time? So a small-scale intervention that's proven successful or effective needs to cover broader areas. And scale-up is really challenging. It's not always successful. So we need to understand how the intervention can be sustainably embedded in a specific system and landscape. Health systems evaluation, as I said, high-quality evaluation is critical for health systems. It lets us make better use of the resources that are invested. It helps policymakers learn what works best in their setting. And many promising health systems intervention, even those that increase coverage, actually fail to deliver or improve health outcomes. So a lot of things in SRH, including, for example, investments in adolescent-friendly health services. So they seem promising on paper, but they're not actually taken up to the extent that we would hope they were taken up. And there's many other examples of interventions which seem promising at a small scale, but when we look at the results after a certain amount of time, we find that they're not making a difference. Okay, so why continue investing time, money, effort into them? And many health systems reforms, including government-set reforms and LMIC, are never evaluated because there's no time to do an evaluation study. There's data limitations, there's scarce resources for actually doing health systems research. So this is why evaluation becomes quite central to the endeavor of health systems and policy research. So part of the problem with, you will have already heard, based on what we just talked about, case studies, part of the difficulty in evaluating a health systems intervention is that it's somewhat different than evaluating whether some drug is effective or not, right? Generally, evaluation questions are framed around what works, why is it effective, does this work? But it's not the most useful way of thinking about public health or health systems research, because many interventions are actually difficult to answer using a traditional randomized controlled trial. So even a basic intervention like digitalization of records, which is now supposed to be carried by a particular cadre of health worker, is not so straightforward in terms of thinking about what it is doing to the system more generally. Okay, and that's exactly what you're investigating, right? You're trying to understand how the process of what seems good on paper, which is digitalizing information systems, is actually pretty complicated in terms of what it creates in the health system, right? So what works cannot be assumed. Health systems are complex, and system reforms have long causal chains and multiple interacting components, which is what you all are doing, right? You're investigating the complexity of the issue. Why does a proven intervention not work as intended? So there's many different reasons, but generally we tend to categorize a program or a service intervention as a relatively simple thing. For example, introducing a new telehealth device, or complex integrated service delivery model. So even introducing a new telehealth device, to me, is not simple. Doesn't sound simple to me. So I would disagree with, I don't even know what a simple intervention in the health system is. I don't think it exists. On paper, it looks like it'll improve practice, but it's often showed not to work, or it might work in one setting but not the other. Why? And the questions that an evaluation team might pose is the intervention wrong? Is it substandard? So is the new technology that's being proposed, is it an operational problem? Does the machine break down very often? Is it a question of, we're assuming a level of, constant supply of electricity for the cold chain, or constant accessibility, connectivity? Yeah, is that the problem? Or was it implemented too weakly? And by weakly, we mean that it was not implemented in a way that would allow it to achieve its full potential. Okay, because locally people decided, no, we cannot equip all the ashas with a mobile telephone to feed back. So we're going to just do it with 30% of them. That should work. Yeah, it should trickle down somehow. Yeah, and often those are those local decisions that are taken to implement the intervention in a way that fits the local resource availability, the local context, and so on. Or was the evaluation faulty? Was there problems with the evaluation, the way it was conducted? Evaluation team comes in, they don't know the setting very well, they've only got 2 weeks, they rush around doing quick survey. It's not really telling us what went wrong. Yeah? Or does it have to do something with the context within which it was implemented? So fundamentally, the idea of introducing a digital health intervention in a context where digital literacy is low in general doesn't make much sense. All right? So when you're thinking about why an intervention might not work as intended, you're thinking about those different things. Is it about the intervention? Is it about the evaluation and how it was designed? Or is it about the context? So I'm going to say context matters, and that's what I've been saying from the beginning, right? Is that how you think about context and what is included in that context is really important to the success or the failure or the suboptimal performance of certain initiatives. Okay, when we think about steps in evaluation planning, we normally think about engaging stakeholders. We try to describe the program, okay, or the intervention. We are focusing on evaluation design, gathering evidence, justifying conclusions, and ensuring use and sharing the lessons learned. But what I'm going to focus on here is this step, describing the program. Because very often, we bring in an intervention in the health system or an initiative, but we don't thoroughly, adequately express how this is intended to work. So going back to the principles of a realist approach. So through what mechanisms do I think that equipping ashas with a mobile telephone and an app to upload information, how do I think that's going to impact on improved, whatever it is, health information systems for a particular program? Okay, which is exactly what you're doing now, is you are thinking through what is impacting on digital literacy, and ultimately how is digital literacy impacting on the program. So you are thinking through a conceptual framework in some ways is already offering us some theory of what's happening. Yeah. So describing the program is sometimes, and we're just jumping forward, but essentially For good quality evaluation or intervention and evaluation design, we talk about something called a logic model. Sometimes it's referred to as a theory of change. But essentially, we are trying to assess how my inputs are going to reach my outcomes and my impact on whatever it is I'm trying to improve. Yeah? And we say that this is sort of our mechanism. So there's lots of different language used, but essentially, a logic model is constructing the pathway from this is what is required to deliver the intervention or the initiative, training, infrastructural changes, top up in terms of salary, whatever it is. And we want to achieve improved digital literacy to be able to implement the program. But what are the steps in between? And why is it important to articulate those steps? Because I want to measure them somehow. Is the implementation of this intervention happening as was intended? Now, what I'm going to argue is that this all looks very nice, yeah? And you might say, yeah, we can measure all this. We're going to measure the number of staff, the time, the money, the equipment, and then we're going to look at our outcomes, we're going to measure them, and then we have a bunch of things. How are we going to get there? We're going to conduct workshops, we're going to conduct trainings, we're going to provide counseling, we're going to monitor, yeah? But what we're missing is that this model, implemented in Karnataka, implemented in Punjab, somehow it's different. Why is that? Why are we getting different figures? Because we're not thinking about context, yeah? So the role of context in logic model designs, construction, and usage is often overlooked. We tend to only depict a set of very specific contextual conditions that are directly targeted by the program, but we ignore the other underlying conditions that would contribute to the problem or the program that's aiming to change the problem. And if you have a simple logic model, you might overstate what the intervention can possibly do, and you might provide misleading information about the possibility of replicating it somewhere else. So we think we need to incorporate context. And this is where Hpsr is very good, because Hpsr by definition says system components are linked, but the system also exists in a context. So what is the context and how do we look at it more closely? So context matters. If you're interested in improving a program or a service, you need a better understanding of how the environment, yeah? And the environment is a social environment, it's a political environment, it's an economic environment, it could be a geographic issue, yeah? Accessibility of the service, how people are reaching it. How is this going to impact on the success of your initiative? But most of the research and practice on healthcare is acontextual. There's little mention of context, or context is some kind of black box. You have it somewhere in the diagram, context. Not explained, yeah? It's part of the background, or it's even considered unwelcome noise. We've got to control. We've got to separate out the contextual factors, because we want to really assess the intervention. We're pretending that we're applying it in optimal conditions, but it's the real world. Okay, there's never going to be super experimental. We're not robots, and we're not operating on a blank canvas. Yeah. So content is a critical ingredient, or a set of ingredients that may be the most important factor in achieving change. Sorry, not content, context. And not understanding and taking into account context risks a huge waste of resources, money, and effort. Evaluators have recognized that the success or the lack of a success of a program, intervention, or project depends on the specifics of the context in which it plays out. So what do we mean by context? And there's a lot of work by the MRC, the Medical Research Council, in Britain on understanding the role of context, particularly for complex interventions. And basically now we've come to a point where we would argue, based on systems thinking, that any intervention, any initiative in the health system is going to be complex. So what's meant by context? The why and the when of change and concerns itself, both with influence from the context external to the provider such as economic, social, political, but also internal to the system or to the organization. Resources, capabilities, structure, culture, politics. Okay, so when you think about the intervention, you're thinking what's happening inside the bounded area of my clinic, my facility, my hospital, my system, as well as how the broader contextual determinants are impacting on what goes on in the system. It's also, another definition is a combination of factors, including culture, that accompanies implementation and evaluation of the project that might influence its results. So geographic location, timing, political, social climate, etc., and other things that are going on at the same time as the project. So the totality of the environment. So let's discuss these two in turn. External context, internal context. So the external is the political and regulatory environment in which healthcare providers operate. Very relevant for you guys, for the PPM. Yeah? What is the external kind of, I think you've included something like perceptions of the private sector and the public sector. But it's also the regulatory environment. Yeah? The role and the power of health professionals. So you might say this sounds more internal. So how are doctors versus nurses ranked in terms of the prestige or the authority or the power that they hold? But actually, it's also linked to factors that are external. So what you might call medical paternalism, which means there is a bias towards doctor-led systems, happens in many countries where there is a kind of bias towards the medical profession, training in certain types of medicine, quite a male-dominated profession still, and so on. So these are sort of social and cultural factors that influence who gets into medical school, who by definition then holds authority or power in a certain sphere. Social and ideological movements such as consumer rights and health-related movements, for example, campaigning by patient groups, can also have an influence on your intervention. So if there's a massive lobby outside the system, because a lot of people are affected by something like, I don't know, post-COVID, everybody had burnout, right? So there might be a lot of lobby, which leads to workplace changes to accommodate the fact that more people should be allowed to work from home, et cetera, okay? But that's just an example. But there might be something else whereby you have a strong activism around a particular health issue, which is shaping the way an intervention will be taken up or not. So going back to the topic of peer networks in HIV care, if you've got a very strong lobby in the country which says we've got to invest more in people-led movements and peer networks, etc., that might support or enable the intervention that you're doing in your health system. It's obviously also the technological environment. Is the therapy, is the equipment, is the space, is the infrastructure adequate? All right? Those are sort of internal, but they're actually determined by the external environment, because how much resources are pumped into the health system, and specifically equipping the health system with the supplies, the drugs, the supplies, and the technology. So all of these factors will shape the effectiveness of programs or service interventions. But we also have an internal context. So this is once we step into the facility. And that context is things like physical layout of the clinical environment. Yeah? The diversity of patients, clinicians, staff, the size, the scope, the scale of the tasks involved in delivering healthcare. So we mentioned different types of health workers in the Indian context. If you're introducing a new intervention, but you're not taking account of the fact that they already are having to manage 6 programs, that's going to be problematic, right? Because you're not taking into account the internal dynamics of the work burden already. Financial stability and economic incentives. So some of you were mentioning something about transfers, frequent transfers in positions, frequent movement. That is obviously instability and uncertainty that's going to affect how you're able to implement your intervention. Standards and values of care, organizational culture and leadership. This is something we'll get into next week. and relationships between patients, carers, healthcare providers, support staff, and so on. So it's a lot about social relationships as well. What does the community, the patient population expect? What are they able to expect and demand of the health system, and vice versa? And then, of course, there's something which we refer to as practical wisdom or intuitive knowledge, which is essentially all those things which are never really documented but are part of the culture of care within the Indian system versus system somewhere else. So let's just go to the point about what makes an intervention complex. So we're saying essentially we are thinking about contextual factors externally and internally, which are adding to the challenge of evaluation. Yeah? And I said that most health systems interventions are complex. So here's a little diagram: simple, complicated, and complex. So this is something that's been used often to try to explain the difference. So a simple intervention is it's like following a recipe. Yeah, you need the recipe. Expertise is helpful, but you don't really require it. As long as you follow the steps of your recipe, you're going to be able to make that omelette or whatever it is. Sorry, omelette is a bit basic, but you know what I mean, right? The best recipes give good results every time. Doesn't matter who's using them, okay? You might say, no, but I'm not familiar with these strange ingredients or whatever. But if I give you the ingredients, you follow the steps, you understand the steps, you can produce the same cake as I can, okay? You might say, yeah, but what about the oven? What about the this? What about the that? Okay, well, good. You're thinking like a health systems person. Okay, a complicated intervention is sending a rocket to the moon. Why? Because the formula are critical. So sending one rocket increases assurance that the next will be okay, but you need very high levels of expertise in multiple fields. Rockets are similar in critical ways, and there's a high degree of certainty in the outcome once the original issues are solved. But it's more complicated in terms of the steps that are on that checklist. Yeah? A complex intervention is raising a child, because the formula has limited application. You can read so and so many self-help books, but your child is not a robot, right? So it doesn't matter how many books you read, although we all do that, we all read those books. How am I dealing with this 12-year-old adolescent turbulent time? And you get tips, but still it's going to be an individual trajectory, right? So raising the child gives experience, but no assurance of success with another child. The expertise can contribute, but it's neither necessary nor sufficient for success. Each child is unique, has to be approached individually. And there's uncertainty of outcome returns. You hope for the best, you do the best you can, but we never know, you know? Did I think my child was going to turn into a science freak? No, I didn't think so. Okay, I thought he would be a social scientist, but sadly it's going more in the direction of natural sciences. No, I'm just kidding, but it's interesting because you always think that you're shaping them in a certain way and then they veer off to the other direction, right? So it's complex. So what makes a health systems intervention complex? Interventions in the health system are generally complex because we have a number of interacting components, as you will see from your diagram. We have groups, we have levels, meso, micro, macro. We have settings targeted, different settings. So community, tertiary level, primary level, whatever. They're all implicated in some ways. Even with the road trauma, road traffic injuries, you're thinking about the trajectory of what happens when the accident happens up to the point where you get to the hospital. They've also got different environments, yeah? You have many different behaviors that are targeted, usually. It's looking at how the provider is going to behave, it's looking at relationships, it's looking at the client behavior, and there's a degree of flexibility in how the intervention can be implemented. So there's always an interaction between the intervention and its context, either internal context, but also external context. So complexity and context are closely related. So even a relatively simple intervention can be complex. Let me give you an example. We're going to implement an appointment system in a level 1 health facility so that we reduce waiting times. Tell me why you think this might be complex. What does it depend on? What does the success of this intervention depend on? What are you assuming? Anyone? Okay, patient flow is not uniform, good. But you're putting in an appointment system. You're saying, okay, so from now on, we're going to send people in advance a specific time that they show up at the facility. This is particularly relevant, for example, in the context that I've worked in, Southern African context, there's no appointment system. So everybody shows up, starts coming in from 4 a.m. and sometimes sits there for 7 hours until they're seen. Yeah? So patient flows change. What else? What else makes it complex? Yeah, good. Okay, not every type of appointment is going to be the same. Some things might have to be changed last minute. What else? What else makes it complex? How is the appointment system being administered? Think about that. What's the technology behind it? Resources for what? Good. Yeah. How is it being implemented? Yeah. Am I sending people SMS reminders? But then how realistic is that? Yeah? Anything else? What else am I assuming in terms of this reducing waiting times? There might be something around the infrastructure. Yeah? Waiting times, I need waiting spaces, I need to think about where are people waiting, maybe I need to triage them differently, okay? So why is this complex? Because it requires some change to working culture and among patients. If, for example, in the South African setting, when they introduced appointment systems, people still showed up at 4 a.m. Why? They didn't trust it. And they thought that for years there had been ways that you would pay the security guard a little extra, then you could move up, or your relative was somewhere in the queue and you could do this. So if you have been used to an unjust system for many, many years, just because an appointment system comes in, it's not like everybody suddenly abides by the new rules, right? The healthcare workers need to be trained on the system of documenting appointments and informing of any changes. So that's complicated because there's going to be loads of people that don't show up on time. So what do? Do you then move to the next one, and how do you inform them? So it's complex, right? So it assumes everybody's going to adhere to the scheduling system, including patients, for whom, especially if they have some condition or something that is bothering them, circumstances might change. Okay? So even something that seems very simple on paper is actually complex to implement. Okay? So I'm going to give you, as a final thing, an example of a health systems intervention, and this is looking at GeneXpert, which is a diagnostic technology for looking at drug-resistant TB strains. And this was implemented in South Africa in 2011. And the South African government was very proud that they were among the first countries to be able to roll this out, roll out and scale it up quite quickly. Yeah. So in terms of the mathematical modeling work that had been done, they predicted that this diagnostic technology would save healthcare systems lots of money by earlier diagnosis. And what happened actually was that when they evaluated the rollout in countries such as Brazil and South Africa, which were countries to take this on from an early point of view, it revealed quite a different picture. Empirical treatment practices, adherence to protocols by providers and patients, availability of treatments post-diagnosed, all in the early phase of rollout, reduced the impact of having GeneXpert in place, or actually led to cost inflation. So this was, in the beginning, was the campaign, was all over the media. Was the health minister doing a GeneXpert test himself? If a minister can do it, can't be that hard. Yeah? And it was thought of as a real game changer, a historical breakthrough in TB diagnostics. Accuracy, speed, high sensitivity, specificity, capacity to diagnose new complex forms of TB, high levels of political and donor endorsement, and really a matter of national sovereignty, okay? And you have the same situation in India. Often the reforms are about nationalist pride coming up. Every country has the same, right? So this in South Africa was a big deal in 2011. So what we were looking at from a building blocks point of view is what does implementation of GeneXpert mean for different aspects of the health system? So we were trying to look at what is the cost effectiveness of the technology, okay? From the point of view of the governance, what is the management culture? What was going to be the arrangements to monitor, to supervise, to assure quality? How user-friendly was the algorithm to decide whether somebody's sample would go forward for GeneXpert or not? What were the requirements from a technical point of view for optimal functioning? And also, what was it perceived really do the health workers really believe in the capacity of this technology to make a difference to their own work flow and burden? And in terms of information systems, who's reporting and recording the health results? How are they being communicated? And in terms of the health workforce, what was the division of labor in the clinic? What was the level of motivation of health workers? And what is the accountability? So what we found, and this study is part of a larger study that was conducted to evaluate GeneXpert, is that there was no evidence that Expert improved the cost effectiveness of tuberculosis diagnostics, at least in the early phase. In terms of the governance, there was a lot of confusion because there were two algorithms in place. It was very difficult to introduce change in the early phase, and people didn't know what to go by. So this initiative came in with a lot of fanfare, but nobody was actually ready for this massive change. In terms of the technical requirements, the power supply was erratic. So you had machines standing around, not working, gathering dust. And therefore, they also had a limited perceived value. They had a limited perceived value. Why? Because the health workers would often say, it's not about the patients that get into the system. I'm much more worried about the patients that are lost to my system. This machine isn't helping me deal with all my loss to follow up. Okay? In terms of the information systems, there was a lack of confidence and consistency in reporting results and poor coordination of the internal referrals required to make sure that putting this new expert way of diagnosing drug-resistant TB would actually lead to better referrals. So you can't assume that just by improving your screening, you're going to improve the rest of the pathway, right? And in terms of the health workforce, the diagnostic processes were handled by different staff, which hindered continuity of care, and there was often a shortage of space. So this is a nice quote by one of the TB nurses. I was certain that we're going to defeat this elephant, in other words, drug-resistant TB, but through implementing GeneXpert. But unfortunately, things are not going the way I thought. We detect TB quick, but the treatment we must give, and then the defaulters, that's my challenge. So in terms of the health system's context and its influence on uptake of GeneXpert, and here we're looking at context and complexity. In a dysfunctional health system, healthcare workers felt absolutely powerless to make any impact on the TB epidemic. There was low motivation, limited ownership, and perceived value of the GeneXpert, and there was poor adherence to the algorithm. There were also conflicting perceptions of accountability for TB services among the staff, and that was really a barrier to successful integration, at least in the early stage, of GeneXpert. In the more functional health systems that seemed to be working better, the integration of Expert was facilitated by a sense of shared responsibility for implementation, collective problem-solving techniques to support internal processes and procedures, and maintenance of referral networks. Okay, so the study that Kerrigan McCarthy did was actually a study that ended up looking at the implementation of Gene Expert as the case study, and she looked across, I think, 19 different facilities in different provinces and found that some facilities were doing a lot better than others, so the functional and the dysfunctional, okay? So I'm just going to end on this slide. So taking away the message for today is we need to understand complexity of the intervention components, but also complexity of the internal and the external context to inform your evaluation. Think about interventions or programs as events in the system. You're introducing something new, yeah? And in evaluation, consider intervention components in the system within which it's implemented. So context is always important. Move away from the binary question. Does this work? Yes, no. But try to understand more broadly how the intervention is going to interact with the context, given all the complexities that it invokes in terms of the system components and how they interact. Okay? We're going to stop there. And we're going to give you a pause, and if you want to ask any questions at all.